أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان वेलकम आज की एक नई क्लास के साथ। हमेशा की तरह क्लास शुरू करने से पहले अहम बात, रिमेंबर फेलियर इज़ नॉट फेलियर, इट्स जस्ट अ पाथ टू द सक्सेस। एवरी फेलियर इज़ जस्ट अनदर स्टेप क्लोजर टू अ विन, सो नेवर स्टॉप ट्राइंग। It is not FSC exam, this is not school exams, this is a professional exams. So whenever you give exams and you are unable to make it, don't get disheartened. You start again, try to find out your mistakes, what were the reasons that you couldn't succeed, and try to improve. Today the topic of our short case discussion is neurofibromatosis. So the command can be, this is a 4-year-old boy or girl with multiple hypopigmented marks on skin, do general physical examination and relevant. So after introduction and consent, you do the hand sanitization and expose the child. Like all short cases, you start with general look and just appreciate how the child looks, whether he is sick looking or well looking, he is cyanosed or having respiratory distress at rest, is there any pallor or jaundice, what is the nutrition status of the child and apparently, and is there any diagnostic or dysmorphic features. Then you start with the status, check whether the child was conscious or cooperative during the examination. And as a GP, so start with the anthropometry. You check the height, so for disproportionate short stature, and for that you need to upper and lower segment, which can be decreased due to scoliosis. Then weight, then you check the OFC for macrocephaly due to hydrocephalus due to aqueductal stenosis. Then you check the fingertips and nails for the cholionicia, leukonekia, clubbing, BSR testing marks, palms, pulmonary edema. Then the palms for pulmonary edema and pallor, wrist for the pulse, rate, rhythm, character, radioradial and radiofemoral delay, respiratory rate, temperature, arms for the BCG mark, and you can ask, do the BP if you don't have time, don't forget to offer it at the end. Heads for eyes, look for the proptosis due to optic glioma, decreased visual acuity, ptosis due to plexiform neuroma of the eyelid, strabismus, extraocular movements. So after checking the extraocular movements, scan the skin for cafe au lait spots. You have to measure the maximum disc size and number, scratch marks due to the pruritus because of the increased release of mast cells by neurofibroma, axillary flattening in the mid-childhood only. Then abdomen for the mass because of the large visceral fibroma, new puberty and tenor staging. Spine for scoliosis and spinal neurofibroma. Gait, hemiplegia which can occur due to CVA, secondary to hypertension. Then rapidly screen motor system for any abnormality and ask for the blood pressure and plotting of the height and weight on the centile charts. I have made a hypothetical description. You can practice your own description before the exams for every short case. So this will make you fluent during the exam. I have just examined 4-year-old child who was conscious and cooperative during my examination. He is well looking, undernourished child without obvious respiratory distress and cyanosis at rest. There is no pallor or jaundice, no diagnostic or dysmorphic features. His height is 85 cm, which is below the third centile, with a short upper segment. OFC is 59 cm, which is 2 standard above the mean, and weight is 25. Apology for the break. OFC is 59 cm, which is 2 standard above the mean, and weight is at 25 centile. The heart rate is 90 per minute, respiratory rate is 30 per minute, and blood pressure is 120 per 80 millimeter of mercury. There are multiple hyperpigmented spots over the trunk. The maximum size is about 10 millimeter in size. There is axillary and inguinal freckling and scoliosis. Tenor stages was prepubertal, no mass was palpable in the abdomen. Examination was unremarkable, though I would like to go for a slit lamp examination. Hearing was intact, gait was normal, and there was no focal neurological deficit. So how to investigate? there's a NF1 gene mutation. Then you can go for the MRI brain, where you can see the focal areas of demyelination present as UBOs, that is unidentified bright objects, which are hyperintense T2 weighted images in the cerebellum, basal ganglia, optic tract, internal capsule, and globus pallidus. So the treatment is supportive. You have to treat the treatment of the fats and hydrocephalus. If there's tumor, you treat the tumor, and there's genetic counseling. So the complications are hydrocephalus, epilepsy, generalized tonic-clonic and complex partial fits, brain tumor, increased risk of ALL, Wilms tumor, pheochromocytoma, rhabdomyosarcoma, precocious and delayed puberty. Neurofibromatosis, it's already called as von Reckling-Hausen disease. It occurs due to an abnormality of neural crest differentiation and migration during the early embryogenesis, and it is inherited by autosomal dominance pattern. So neurofibromatosis type 1 is diagnosed by a clinical criteria in which you need 2 out of the 7 criteria required. Number 1, cafe au lait spots, which should be at least 6. They should be greater than 5 mm in pre and greater than 15 mm in post-pubertal patients. They must be present from birth, obvious by 1 year, and present in 100% of the cases. They smear the face and they are found on the trunk and extremities. So number 2 criteria is greater than 2 to 3 mm hyperpigmented areas. Freckling appears in mid-childhood. Number 3 is 2 or more lesion nodules. Slit lamp examination is required for identification, and they are rarely seen by the naked eye. Greater than 75% are present in neurofibromatosis 1, while they are absent in neurofibromatosis 2, and they occur 100% by 21 years of age. Plexiform neuroma is found in the blood vessels, GIT, skin, peripheral nerves under hormonal influence, so appear at puberty. Skin over the plexiform neuroma is more pigmented than cafe au lait spots, rubbery lesion with purplish discoloration of skin. Plexiform neuroma can cause overgrowth of an extremity and bone. Sphenoid dysplasia, which is pulsating proptosis. Optic glioma, which occurs in 15%, visual acuity disturbance. There is a swinging flashlight test, and there is afferent pupillary defect. Light in an affected eye causes pupillary dilatation rather than constriction, and first degree relative involvement because it is autosomal dominant inheritance. Neurofibromatosis type 2 is 10% of the cases. In that, you need one of the 2 criteria. Number 1 is bilateral 8-nerve Schwann neuroma, or number 2 is a parent or a child or sibling with a neurofibromatosis 2 or unilateral glioma, schwannoma, meningioma. Hearing loss, ataxia, and unsteadiness, 8-nerve facial weakness, cerebellopontine angle mass, occur in 3rd and 4th decade. So now few of the pictures, these are copied from the up-to-date, and cafe au lait spots, see the hyperpigmented on the back. Now they appreciate the axillary freckling. These are the hyperpigmented. Then this is the example of the lesion nodules, which can be seen in the slit lamp examination. Then this is the plexiform neuroma. See the overgrowth of the limb. Then multiple spinal schwannomas in neurofibromatosis type 2. This is shown by the multiple arrows. So thank you very much for your listening, and this was just the basic guidelines. If in case you come across this patient in your short case, and you can change or improve or whatever you want to do, but the basic aim is you reach to the diagnosis and you find out the complications and the findings. So with this, it comes to an end, and I thank you for being with me. May Allah be our helper, protector, and guide. I will be looking forward for your feedback. Allah Hafiz.